The history, the 40 years old male, he presented to us with left hip pain for more than 5 years, had a difficulty in walking and weight bearing. He's a morbidly obese guy, had a waddling and antalgic gait. I will show the pictures and video later. He had a left side painful hip with reduced range of motion with adduction deformity. Limb length discrepancy was present. He is a known case of post-polio residual palsy was there. This is his pre-op X-ray. So we are concentrating on the left side.
Okay.
That's asymptomatic.
We are talking about the left side.
Yes.
Let's go through the line, starting at the end. What would be your choice to operate this patient?
So it is a dysplastic hip and proximally migrated dysplastic hip. Maybe CT scan may give us better idea.
What kind of implant do you have in your mind if such a patient comes? He's 40 years old, cementless, cemented. What kind of bearing?
I think the socket is not really a problem. For the stem, I would like to keep an SROM kind of an implant.
Yeah, socket is not a problem, but certainly a dual mobility given the history of post-polio residual paralysis, definite dual mobility for me.
So in this kind of dysplastic solution, especially in the Indian population, it's very good to have bantam cups, small cups, and we normally get a CT, and we'll have a stem which will have some kind of version, so something like an SROM, right? Yeah.
First important is your clinical examination. If this patient does not have an active abductor, because if you look at this, there's a coxa valga, hypoplastic trochanter. Patient should have at least grade 3 abductor and extensor. You've got to examine them, otherwise you are going to be in trouble with this patient.
Yes.
If it is a polio. Clinically, you cannot miss a clinical examination
Yes,
for
absolutely.
this patient. Second important, if the abductors are good, probably still for a post-polio and considering the opposite side, you should use a double mobility for this patient because the cup is going to be on the smaller side.
Yes. Next.
Yeah, in addition to the point that has been brought out, that the muscle power is more important than planning the case here. In case there is no abductor, there is no point in going in for any kind of a dual mobility. That will also fail. So the bearing to me would be a dual mobility, or I'll keep the SnapFit cup also ready with me in this kind of case.
Yeah, that's absolutely perfect. Unless abductors are intact, don't go for total hip. And dual mobility, there's a high risk of dislocation because there's an adduction deformity, so muscle imbalance, and there'll be shortening. So once the abductor mechanism is corrected, you can compensate with the shortening.
Yeah. So his spine is reasonably good. There's a spine X-ray, and I'd like to show his pre-op video how he ambulate.
Okay.
Yeah. So the points which we discussed,
Yeah,
the
we
preoperative planning is the key here.
We discussed it
And
already.
Getting templating and counsel the patient as well as family, the implant of choice, introp challenges, achieving the anatomical hip center, introp stability, and expect post-op risk of dislocation and infection. This is how I did a preoperative templating. Any comment about this X-ray? But I didn't use a dual mobility here because I used a SROM to control the version. His abductor power is reasonably okay on the left side. So that's why initially I chose the primary cup.
Vijay, any criticism?
You didn't use a dual mobility. It's not a dual mobility. It's not a dual mobility.
It's not.
I would contest that. Whenever you have some loss of in polio, you have to make yourself safe. You have to use use a dual mobility. Other than that, using a SIM with versional freedom is great. SROM is great, but certainly dual mobility for me.
What's about the high hip center? Would you criticize it?
High hip center is perfectly fine. This is where I would like to leave the cup. Exactly where I would like to leave the cup. Otherwise, you'll get such a big cup. Not a great idea.
Other comments?
Maybe the cup could have been a little bit of horizontal cup. Is it too vertical cup?
Well, yeah, okay. Position of the cup. Some other comments? Okay, go ahead.
You can't comment on the version of the, sorry, I was about to tell you.
It's answered already.
This is where the case, the challenging started. And the first immediate post-op day, the patient had a dislocation. So I took him to the OR. So I attempted for a close reduction. and I given a knee brace to immobilize. When this was happened in the second dislocation within third day. So now the issues which already mentioned by the expert panels, the abductor insufficiency, open cup, and issue with version, it was dislocating anteriorly in extension and external rotation. So the plan now, the option is to go for a revision because there is a multiple repeated dislocation.
He dislocated once or twice?
Twice.
Twice. Very quickly. Surgery or another reduction?
Absolute surgery. The cup has, the inclination has to be changed, and as said correctly, dual mobility is the best choice for these patients. Once you go for THR, it's a train, you have to go again and again.
Would anybody of you would go for another closed reduction?
No.
And no surgery? Okay.
I think it's an important message, Thorsten, that if he's dislocating twice, thrice, whatever it is, I think you must know the cause of dislocation. Without that, don't touch this patient, otherwise they will come back again to you. So best approach for them is whatever the muscle tested, whatever is done, CT scan will be ideal to know the antiversion of both the components. So you will have to rectify whatever is in the trouble.
So the problem is I took for the patient for the revision and counseled the patient as well as the family. The revision of vestibular component. So at this time I went for a dual mobility cup and reduced the femoral stem version, and I could achieve the introp combined version. And this is the post-op radiograph. This is the immediate post-op X-ray after the dual mobility. This is now 6 months and 1 year follow-up. And patient came last week. This is a 3 years follow-up after revising with dual mobility with change in the version. And this is the current video we took in the last week. The patient is stable but pain-free in the hip. The message which we already discussed, the most important part of the whole procedure is getting the good acetabular reconstruction in a proper position. And the femoral version should be adjusted optimally. A high but not lateral position should be accepted. Obtaining a satisfactory coverage is the key step. So the lesson which I learned in this case is proper preoperative planning is the key. Counseling the patient as well as the family. Choose ideal implant and anticipate the intra and post-op issues. Address the issues specifically to prevent further complication. Thank you.